Dr. Cathal Harmon, who is a cancer immunologist in Harvard University, who originally worked as a medical scientist in the HSE here in Ireland. And when he saw firsthand the difficulties of treatment of cancer patients, he thought that there must be a better way to treat patients without the toxic side effects of chemotherapy and radiation. And his research initially focused on liver cancer and how tumours can cripple the immune system over time. And his work now focuses on using immune cells from fit and healthy people to supplement cancer patients' own immune systems and then overcome the tumour's negative effects. And one day, your immune cells could cure someone else's cancer. So before he is going to do his talk, there is a question that you can all log into this website called Menteenature, and there should be a link in the chat that you'll be able to enter this. Is there a link in the chat now? Yeah. So we'll see what the people think at the moment. Would they donate their immune cells to a cancer patient right now? A lot of yes, a lot of definitely. That's great. I don't know if that link is working at the moment, but that's okay. Would you like to take the floor, Cathal? I'll share your screen.
Sure, thanks, Sam. I think that's the first time I've ever actually been introduced to an audience before. Usually I'm the one doing the introducing, so it's nice for a change. There we go. So I got a part-time job during the pandemic as a translator for sign language. You can see me down the corner. So today I'm going to tell you a little bit about my research focusing on how I can take your immune system and use it to cure someone else's cancer. Okay, so how did I get here? This is a question I ask myself quite regularly, especially on the bad days, but also the good days like today. So to answer this, I probably have to go back to the mid-90s, and in what would now be described as a massive security breach and a health and safety hazard, my older sister, who was working in a lab up in Beaumont Hospital, brought me, who was probably about 4 or 5, into the lab to see what went on there. And it was quite an inspiring experience. And after that, I wanted to be a fireman because I used to watch London's Burning every week. A few years went by and I got more interested in science, and I decided to study science in college. And in 2012, I graduated from DIT, and I was lucky enough to get a job in the HSE. I kind of went in bright-eyed and bushy-tailed and got a very decent reality check from working in the HSE. Kind of the sickest patients we ever worked with were cancer patients, and we'd work very closely with the doctors and nurses who looked after them, and they were always the most urgent cases. Someone that once described cancer treatment back then was slash and burn, and it was the equivalent of the Vietnam War, where chemotherapy was napalm, and surgery was sending the troops in with their machetes to cut through the jungle. So thankfully we've moved on a little bit since then. I left the HSE then in 2014 and did a PhD in Trinity, focusing mainly on cancer, but an element of it also focused on liver transplantation. And that's kind of where I developed this kind of idea about transplanting immune cells from one individual to another to kind of cure their disease. So what's the problem? Why do we need this? I don't think we really need to tell people how damaging and dangerous cancer is. It's about 19 million cases worldwide every year, and unfortunately about 10 million deaths. And up to last year, the chances of you contracting cancer is about 1 in 2 in your lifetime. So generally it's going to be a very difficult disease to treat going forward. Thankfully, there has been kind of a major advance in cancer treatment, and this is cancer immunotherapy. So this is a therapy based around your immune system, and to use that to attack the cancer. So in 2013, so this is the year the year after I left college, it was the scientific breakthrough of the year. It was on the cover of Time magazine. I love this caption. It was inside the brutally selective, hugely expensive, and life-saving trials of immunotherapy. And that really encapsulates immunotherapy in a nutshell. It works fantastic in a small number of people, and it is unfortunately very expensive to carry it out. And kind of unheard of for moving at this speed in medicine. In 2018, the kind of creators of one of the immunotherapies received a Nobel Prize in medicine. So you went from pretty much in the lab, on the bench science to a Nobel Prize in medicine in about 10 years, which is really sensational. So how does your immune system actually fight cancer? I could talk for a couple of hours about this and bore the socks off all of you. But to kind of boil it down, there's two different ways it can do this. One is using something called a T cell, and these can recognize, so cancer cells acquire dozens of mutations as they develop. And sometimes these mutations make mutated proteins that our immune system recognizes and go, hang on, there's something not right about this one. And they can kill the tumor cell that produces that protein. So that's a T cell. Then there's a group of cells which can recognize stress in cells. So you can imagine when a tumor cell starts to grow, it starts to push on other cells, it pushes them out of the way as it grows. And all of that kind of friction and mechanical stress causes the cell to become unhappy. And we have a lot of different cells like natural killer cells and gamma delta T cells, which patrol our body looking for these unhappy cells. And they're the cell types that I've worked in so far. So those are kind of the two ways, mutations and cellular stress. So what does immunotherapy actually do? So during the course of cancer, the immune system becomes exhausted. So it recognizes the tumor, it tries its best to kill it, but it's knackered by the time you get to hospital. And it starts to express. You can see these little tags coming out of the T cell on the right, and these are what we call immune checkpoints. So like getting pulled over at a checkpoint by a guard, you're going to have to stop. He might say, well, you're looking a little bit tired. Maybe you shouldn't keep driving. And maybe this T cell shouldn't keep attacking cancer. So it kind of gets the immune system gets a little bit sidelined for a while. And the first type of immunotherapy, the one that won the Nobel Prize, is called a checkpoint inhibitor. Basically what this is an antibody that goes and sticks to those little tags that are on the T cells, and it turns that stop sign into a go sign. So without those tags, the T cell doesn't know, it doesn't realize that it's exhausted. It keeps driving and it keeps trying to kill the tumor cell. The second type of immunotherapy that we have is called a CAR T cell therapy. It stands for chimeric antigen receptor, which is you don't really need to know what it does. Basically, what you do is you take a blood sample from cancer patients. You isolate their T cells, so those are the ones that recognize the mutations. And then you genetically engineer these T cells so they all recognize the same thing, something specific about that cancer that they can recognize. And then you make more of them. You make billions of them, and you inject them back into the patient. And just by chance, last week was the 9-year anniversary of the first successful CAR T cell therapy. So this is Emily Whitehead. She was, I think, 9 at the time. She got a cancer diagnosis. She had leukemia. And a course of CAR T cell therapy cured her. And this is her last week with the doctor who treated her. So there's some wonderful stories out there about how immunotherapy is working for a lot of people. Unfortunately, it only works in about 20% of people. That varies from cancer type to cancer type. Some are as high as 70 or 80%, and some are just zero. You don't get any use. The other rate limiting step in using them is the expense. So a checkpoint inhibitor is going to cost about $100,000 for a treatment, and CAR T cell is going to cost about $350,000 per patient. That's not including all of the other things that go around their hospital stay and surgeries they might need to have as well. So you're still looking at like possibly $500,000 to treat a patient. In situations where countries have socialized medicine or poorer income countries, the economics of 350,000 per patient is very difficult to manage. It's just too costly for most countries. So we need to come up with an alternative to this that's a little bit cheaper and a little bit more effective. So we think we can kill two birds with one stone here. One of the main problems with immunotherapy is that you're asking someone who's cancer patients are generally older. They have an older immune system. It's a little bit more exhausted to start with. So you're asking their immune system to do a lot in addition to fighting cancer. So we think if you can use a younger person's immune system, then you can get around this problem of exhaustion a little bit. And the second one is if you can mass produce cells rather than taking a patient's own cells and manipulating them, you'll reduce the cost of it a lot. Because as the saying goes, time is money. And to make a CAR T cell therapy, you have to do that in a very short period of time where there's a treatment window for that patient. So the faster you do anything, the more expensive it becomes. If you can mass produce things, you can have them on hand, you can take it off the shelf and just give it to the patient. So that makes it a lot cheaper. So is there a history of using other people's organs or parts of their bodies to treat other people? So this is going to be a very quick history lesson of 120 years of research in about 2 minutes. Has anyone ever gotten a blood transfusion? Want to just, if you feel comfortable telling people, that you can put it in the chat. If not, don't worry about it. This is Karl Landsteiner, and this is the man who probably saved your life. In 1901, he discovered blood groups. He basically figured out that before 1901, they used to kind of give blood to people and they would either die or not die. And they didn't really know why. Karl figured out that there was different blood types for different people. And that kind of set up the whole modern medicine and allows us to do a lot of things surgically that we wouldn't be able to do without blood transfusions. Then in 1967, this is a picture of the first kidney transplant. So we started to understand how we could transplant whole organs to people and more importantly, how to stop them being rejected, which was a very important breakthrough. Then in the 90s, we all thought face transplants like that, taking Nicolas Cage's face and putting it on John Travolta's face was science fiction. Last year, we had the first combined face and hand transplant. So we're kind of breaking down those walls that we once considered science fiction, and we're learning a lot along the way about how to do that effectively. So can we actually give someone a new immune system from a stranger? This is our overall goal. The answer is yes. We've been doing it since the 1960s. So this is David Camp. When he was 2 years old, he was born with a genetic defect, and he was the first person to receive a successful bone marrow transplant from someone who wasn't an identical twin. So his big sister, doing as all big sisters would, gave him her bone marrow, and he's still alive today. She saved his life in the 60s, and he's happily married with kids at the moment. So what happens in a bone marrow transplant? The first thing you have to do is get rid of the recipient's bone marrow or their immune system completely. So you do this with radiation and chemotherapy, and it's often used as a treatment for leukemia. So you wipe out their immune system, you take stem cells from the bone marrow and the hip, and then you transplant that into the recipient, and they should reconstitute a new immune system. So some of you might be thinking, Cathal, you're out of a job, problem solved. Unfortunately, bone marrow transplants are a little bit too complicated for the scale that we need to do things at. Worldwide, we do about 50,000 transplants a year. So nowhere close to the kind of 19 million that we want to treat for cancer. One of the other things we learned from bone marrow transplants is that it's very hard to transplant T cells. So those cells that recognize mutations in cancer cells, because if you don't match them very closely between the donor and the recipient, they'll start to attack the recipient. They'll think they're a foreign object and try and kill them. So that's what we call graft versus host disease. So that means we can't use T cells for our immunotherapy. We have to keep those just from a recipient. So what I do and what our lab does is we take those cells that recognize the stress in tumors, and we take those from healthy people, healthy young people, and we isolate those cells. And one thing we can do is we just expand them and we make more of them. And then we can transfer those into a patient. So that seems to be a good option, and it does work. But for what we need to do, we need to be able to mass produce these. And taking a blood sample from one person and expanding cells, it's kind of like blood transfusions. You get maybe